Hey everyone, and welcome to this Clinical Explainer. Today we're putting on our clinical ophthalmologist hats to tackle one of the leading causes of preventable blindness worldwide. We're going to completely unpack the mechanisms and management of glaucoma, along with ocular hypertension. But don't worry, we aren't just going to sit here and memorize a boring list of drugs. Instead, we're going to look at this entire disease state through the fascinating lens of fluid dynamics. Trust me, once you understand the intricate plumbing of the eye, the pharmacology is going to logically fall right into place. Okay, let's dive into this. Here's a quick look at our clinical rounding sheet for the session. We'll start with the disease pathophysiology and fluid balance, then move into suppressing fluid production, enhancing outflow, emergency management, and finally, lifelong care. All right, Chapter 1, the disease and fluid balance. To really get how to treat this condition, we absolutely have to start with the foundational anatomy. So let's start with this crucial definition, and I really want to deliver this with a sense of clinical urgency. Notice the exact phrasing here. Glaucoma is a progressive optic neuropathy. It's fundamentally a disease that damages the optic nerve. Now, while it's frequently associated with increased intraocular pressure, or IOP, the pressure itself isn't the actual disease. It's just the primary risk factor and, of course, our main target for treatment. Because if left unchecked, that high pressure slowly crushes those nerve fibers, resulting in very specific and completely irreversible visual field defects. We are literally racing against time to save the optic nerve here. Now let's visualize this delicate hydraulic balance. It really helps to think of the eye like a bathroom sink, where the faucet is running, but the drain is continuously open. In this case, the faucet is the ciliary body. It constantly produces this clear fluid called aqueous humor. This fluid travels through the posterior chamber, washes over the lens, flows right through the pupil into the anterior chamber, and finally exits out the drain, which is primarily the trabecular meshwork and the uveoscleral pathways, right at the angle where the iris meets the cornea. So a healthy eye depends entirely on the rate of fluid production, perfectly matching the rate of fluid drainage. It's all about balance. But what happens when that fluid balance fails? Well, intraocular pressure spikes, but how it fails dictates our entire clinical approach. On the left, we've got open-angle glaucoma. This is a chronic, completely silent disease. The drainage angle is technically physically open, but over time, the microscopic trabecular meshwork and Schlemm's canal become sluggish. It's like a slow, chronically clogged drain. The pressure builds up gradually, and usually there's zero pain. Now contrast that sharply with closed-angle glaucoma on the right. This is an absolute, drop-everything acute medical emergency. The iris physically bulges forward and suddenly completely blocks the drainage angle. The intraocular pressure skyrockets in a matter of hours, resulting in a rock-hard eye, agonizing pain, and an immediate threat to the patient's vision. With that pathophysiology under our belts, let's transition into Section 2 and look at our first major pharmacological strategy. Think about it. If the sink is overflowing, the most logical first step is to fix the plumbing by turning down the faucet, right? And our heavy hitters for doing exactly that are the beta-adrenergic blockers. Let's look at their mechanism of action, or MOA. These drugs act directly on the ciliary body to block endogenous adrenergic stimulation. This profoundly decreases the production of aqueous humor. We typically lean on two main agents here. Timolol is a non-selective beta blocker, meaning it hits both beta-1 and beta-2 receptors. But taxolol, on the flip side, is cardioselective, so it preferentially targets just beta-1 receptors. Both are applied as topical eye drops and are incredibly effective for managing chronic, open-angle glaucoma. But here's the catch, and you have to be hyper-vigilant about this as a clinician when looking at their adverse drug reactions, or ADRs. Even though these are just eye drops, they can and do get absorbed systemically. Because timolol is non-selective, it blocks beta-2 receptors in the lungs. This means timolol is strictly contraindicated in patients with asthma or COPD. Why? Because it can trigger severe, potentially fatal bronchospasms. So if you have a respiratory patient who absolutely needs a beta blocker, betaxolol is your safer alternative because its cardioselectivity essentially spares those beta-2 receptors in the lungs. Now, another excellent class of drugs for turning off that tap are the carbonic anhydrase inhibitors, or CAIs. The key agents to know here are acetazolamide, which is oral, and dorzolamide, which is topical. Their MOA is actually super fascinating. The ciliary body needs an enzyme called carbonic anhydrase to produce bicarbonate ions. These ions get actively transported into the eye, and water just passively follows them via osmosis to create that aqueous humor. So by blocking this enzyme, CAIs essentially halt that osmotic water flow, drastically reducing fluid production.
However, systemic use of CAIs like acetazolamide comes with a really unique and honestly bothersome side effect profile. Because you're messing with bicarbonate systemically, you can induce a mild metabolic acidosis. So patients will often complain of feeling just generalized malaise, loss of appetite, and GI upset. Plus, altering the urinary pH greatly increases the risk of precipitating kidney stones. And interestingly enough, even with the topical drops like dorzolamide, patients frequently complain of a lingering, highly metallic or bitter taste in their mouth. That happens as the drug drains down the nasolacrimal duct right into the back of the throat. All right, moving right along to Section 3, enhancing fluid outflow. We've turned off the tap. Now let's open up the drain.
Today, the absolute first-line therapy for enhancing outflow are the prostaglandin analogs. We're talking about drugs like latanoprost and travoprost. Their mechanism of action is highly targeted. Instead of acting on the primary trabecular meshwork drain, they specifically act to increase fluid drainage through that secondary, alternative route we mentioned earlier, the uveoscleral pathway. They are incredibly efficacious, and a massive benefit for patient compliance is that they typically only need to be used once a day.
Honestly, the ADRs for prostaglandin analogs are arguably the most fascinating in all of pharmacology. These drops cause permanent cosmetic changes to the eye. They literally increase the melanin content in the iris, which can lead to permanent iris pigmentation known as heterochromia iridis. So a patient with hazel or green eyes might permanently develop brown eyes. On top of that, they cause hypertrichosis, meaning a darkening, thickening, and excessive growth of the eyelashes. This side effect is so prominent, actually, that a variation of this exact drug is marketed cosmetically just to grow eyelashes. Pretty wild, right?
Next up in our outflow enhancers are the miotics, or cholinergic agonists, with pilocarpine being the classic prototype. Now, pilocarpine's MOA is heavily mechanical. It has a direct muscarinic action that tightly constricts the pupil, which is called miosis, and forcefully contracts the ciliary muscle. Imagine the ciliary muscle as being physically tethered to the trabecular meshwork. When pilocarpine makes that muscle violently contract, it literally stretches and yanks the trabecular meshwork open, allowing the trapped aqueous humor to rapidly drain out.
But as you can probably guess, that violent mechanical pulling comes with some severe risk warnings. Because the ciliary muscle controls the lens, contracting it artificially induces myopia, or severe nearsightedness, so the patient's distance vision will blur. That constant, intense muscle spasm also causes a deep, throbbing headache or brow ache. And most dangerously, because the anatomy of the eye is all so intimately interconnected, this forceful pulling on the intraocular structures carries a legitimate risk of causing retinal tears or even detachment.
And this brings us to a drug that brilliantly illustrates the sheer elegance of modern pharmacology, the alpha-2 agonists, specifically brimonidine. Brimonidine features a highly desirable dual mechanism of action. It doesn't just do one thing, it brilliantly hits both sides of our hydraulic equation. By stimulating alpha-2 receptors, it decreases the production of aqueous humor from the ciliary body, and it simultaneously increases the uveoscleral outflow of that fluid. It's an incredibly versatile topical agent, widely used in open-angle glaucoma. You do, however, have to keep an eye out for its signature ADRs, which frequently include allergic conjunctivitis, ocular hyperemia, or systemic drowsiness.
Okay, Section 4, Emergency Management and Drug-Induced Risks. We need to shift gears here.
We are stepping away from chronic daily management into the acute phase. Picture this: a patient presents to the ER with an acute closed-angle glaucoma crisis. They're screaming in pain with a pressure of 60 or 70 millimeters of mercury. Eye drops aren't going to cut it here. You need systemic osmotic agents, primarily intravenous mannitol. The MOA here relies entirely on sheer osmotic force. Mannitol creates a massive osmotic gradient in the bloodstream that literally sucks water right out of the vitreous humor of the eye, rapidly shrinking the eye's volume and dropping the pressure before the optic nerve dies. However, the strict safety warning here is for heart failure patients. Pulling all that fluid into the vascular space causes sudden circulatory overload, which can easily trigger fatal pulmonary edema in a compromised heart.
Let me pause here for a second and pose a critical diagnostic question. If a patient comes into your clinic with sudden, excruciating eye pain and a massive pressure spike, but they have absolutely no prior history of eye disease, what systemic medication might they have recently started? Specifically, what is TAC?
Well, TAIC stands for topiramate-induced acute angle closure. Topiramate is a very common systemic medication used for migraines and as an anticonvulsant. In idiosyncratic cases, this drug triggers massive cilio-choroidal effusions, basically swelling of the tissue right behind the iris.
This swelling violently pushes the entire lens iris diaphragm forward, instantly pancaking the drainage angle closed. The result? Sudden onset, blinding eye pain, and blurred vision. And the treatment here isn't just eye drops, it's immediately stopping the offending toporamate.
So the crucial point here is that systemic medications are often the hidden culprits in ophthalmology. We really must memorize these high-yield clinical warnings. First, corticosteroids, like dexamethasone. Long-term use, whether it's topical, oral, or inhaled, actually alters the trabecular meshwork matrix, leading directly to chronic steroid-induced open-angle glaucoma. Second, systemic anticholinergics, like atropine or even common antihistamines. These drugs cause pupillary dilation. In a patient with anatomically narrow angles, dilating the pupil bunches the iris tissue up into the drainage angle, directly precipitating an acute closed-angle attack. They are strictly contraindicated in these patients.
All right, let's pull all of these clinical pearls together as we approach the final section of our explainer.
We've seen today that treating glaucoma is far more complex than just prescribing a generic drop to lower pressure. It's a nuanced, lifelong endeavor. It requires continuous monitoring of intraocular pressure, visualizing the optic nerve, and carefully selecting the precise mechanism of action, whether that's decreasing production or enhancing outflow, that perfectly suits the individual patient's unique biological plumbing. And all of that while carefully navigating systemic side effects. By mastering the fluid dynamics, you really do master the pharmacology. But it leaves us with a provocative question. As we uncover more about the eye's intricate plumbing and its genetic pathways, how close are we to developing therapies that can outsmart this silent thief of sight before the pressure ever even begins to rise? Thank you so much for joining me on this explainer, and remember to always check those medication lists.